Good morning. Welcome to the Department of Medicine Grand Rounds. Today we have a special guest, but before that, a few comments. We usually spend just a couple of minutes remembering and celebrating people and events that have changed the way we think about medicine, biology, human nature. And so there are three people today that I want you to remember. One is Dmitry Iosifovich Ivanovsky. I did my best. He was born on this day, back in 1864. He was a Russian microbiologist who in 1890 was commissioned to study why tobacco was dying. And so he was looking at mosaic disease in tobacco, and through a number of very detailed microscopic and filtering processes, he realized this was a parasite that was much smaller than a bacteria that was later going to be recognized as what we call viruses. So in fact, he had discovered a new form of life. This is back in the late 1800s. Florence Rena Sabin. Florence Rena Sabin. You should remember that name. She was born on this day, November 9th, 1871. She was an American anatomist and a physician who was one of the first female physicians who decided to have a career in research. And she studied the lymphatic system and how it developed during embryogenesis. In 1903, she became the first woman on the faculty of Johns Hopkins University. In 1925, she headed the cellular immunology section at Rockefeller Institute. And in 1926, she was the first woman elected to the National Academy of Sciences. And then we remember Hargobind Khorana, K-H-O, Khorana. Hargobind Khorana was an Indian-American biochemist. He won the Nobel Prize. In fact, he shared the Nobel Prize in 1968, Physiology or Medicine, with Drs. Nuremberg and Hawley. And what they did was to study how DNA information is transferred. Remember that after Watson and Crick that described the DNA helix structure, it was unclear of how that information containing that structure will be delivered to develop proteins and all the traits that we know the cells can do. So he studied how that message was transferred. He studied messenger RNA. And he was one of the first, in fact, the first who actually developed a gene in the laboratory, just with pure chemicals in his laboratory. So we remember these three people because they were born or died on this day many years ago, and they're still changing the way we think about medicine. With that, I leave you with Dr. C, who's the head of our BMT division. He's going to present our distinguished guest of the day.
Good morning. It is my great pleasure to introduce today's Grand Round speaker, Dr. Hillard Lazarus, Emeritus Professor of Medicine at Case Western Reserve University. He was the former director of the BMT program there at the University Hospital Case Medical Center for more than 25 years. In fact, most importantly, he was the first BMT fellow trained under Dr. Roger Herzig, who is the founding director at the Case as well as the UofL. He also working very closely with the late Dr. Jeffrey Herzig and made some very significant contribution in high-dose chemotherapy for many types of blood cancers. Dr. Lazarus received his undergraduate degree from Carnegie Mellon University and medical degree from Rochester University School of Medicine. He began his medical career as an intern at Case Western Reserve University and then moved up to the tenure full professor there. He's one of few faculties I personally know to devote his entire medical career to a single medical institute, and I don't know any audience here has been like that. And I had a great pleasure working with him at the Case when I obtained my first faculty position after fellowship training. He has had an extremely productive career in hematologic malignancy and bone marrow transplantation fields. He served on many committees leadership position in the ECOT, CIBMTR, and BMT-CTN. Those are national and international clinical trial organization in our field. And his position including the first chair of the BMT committee at the ECOT and co-chair of lymphoma committee at the CIBMTR. He published nearly 700 manuscript that covered many areas of leukemia and bone marrow transplantation field. After recently retired from case, Dr. Lazarus still remained professionally very active. He continued to serve as the editor-in-chief in 2 high-impact journals in our field, bone marrow transplantation as well as blood reviews. Welcome, Dr. Lazarus.
Thank you. Good morning, and thank you so much for inviting me to come to your great medical center to speak. I'm overwhelmed to hear that's very nice to share these anniversary stories about 3 people. I hope I don't disappoint you. These are pretty tough acts to follow. I'm going to be talking today about a very focused area. I realize this is a broad audience, and I am talking about a very narrow topic, but I think it's very important to sort of frame what we're doing in the bone marrow transplant field. And these are my disclosures for stuff that I do in addition to my other academic activities, but none of this has any bearing on the data that I'm going to show you, but I just want to be totally transparent. The title that I chose is very unique, No Such Thing as a Normal Donor, and basically and I'll come full circle at the end of my talk to explain this, but basically the allogeneic blood and marrow donors are not normal patients. They're not patients at all. They're altruistic persons who are saving a life by putting themselves at risk to give up blood or bone marrow or other tissues to support a life. And in my long, long career, and as Dr. C told you, I was at the same place for 43 years, I never, ever encountered any volunteer donor, that's the proper term, who didn't have some medical issue that wasn't important when they undergo this very detailed evaluation, which is now, fortunately, what we do when we see people who are going to be a donor for someone else. So for those of you who don't know transplantation, I'm going to briefly review some of this for you. I think what is exciting is that, as you heard, I had the great fortune to work with Jeff Herzig, the late, great Jeff Herzig, Roger Herzig, his brother, and other people. And we were doing hematopoietic cell transplantation when people couldn't even spell it. Now it's on all the talk shows, etc. There have now been 1 million, this is 2013, there's been 1 million transplants that have been undertaken, and physicians and caregivers and patients and their families all should be commended, because if we just look at the U.S. alone, 20,000 transplants are done annually, 65,000 worldwide, with a continued growth rate. So this is a life-saving art that is applied, and it's something that we now have to save lives. Now, just to briefly remind you what a transplant is. I have on this slide, it's a little busy, but I wanted to make sure I hit all the high points. Why do we do transplant? Well, if somebody has usually malignancy, we can do transplants to eliminate an immunodeficiency or a hemoglobinopathy or some other things. But the vast majority of transplants are done for cancer. And the idea is that if you give more chemotherapy or radiation therapy together, you're going to kill the marrow production, so you have to rescue the patient. So if you can restore hematopoiesis when you give these cells from a donor, if the donor and the recipient are histocompatible. If you just take any cells and put it into somebody, the immune system of the recipient will reject those cells. That's called engraftment failure. The cells are collected and they're infused intravenously, and there's a whole literature on why these cells have the smarts to circulate in the bloodstream and to find their way back to the marrow and start to grow. And obviously, there is a period of time, an obligate period, where it takes them a while to grow up and to make blood. And obviously, faster regeneration is better, and I'll get to that, because neutropenia can be fatal. Severe thrombocytopenia can be fatal, but there are other organs that are injured in the course of getting high-dose chemotherapy. Now, we used to think it was just the chemo that got rid of the disease. Not true. In allogeneic transplant, the immunologic effect of the donor cells or these are effector cells, they kill the malignancy. We call it graft versus tumor, but it's a two-edged sword because there's an allogeneic effect of these same cells attacking host organs, and we call that graft versus host disease. And depending on the degree of match, you can have more or less of that, and it can be fatal because even though we give immunosuppressives to slow it down, that's a problem. So I will refer to graft versus host disease, either acute, which occurs within the first 100 days, or chronic, which occurs afterward. And there are different syndromes. Now, when I first started doing transplantation, it used to be that you would test blood and marrow and other things between a potential donor and recipient, and there was a 1 in 4 chance that you would match your brother or sister, and there was 3/4 of the chance doing Mendelian genetics because the HLA type is inherited codominantly on the 6th chromosome per Gregor Mendel. And what has happened in this country and worldwide, and these are data from the National Marrow Donor Program, the numbers of births in the world are going down in most places. And so this 40-year decline in birth rates means the likelihood of finding a match among a brother or sister is now down. And so we've had to rely on alternative donors, that is not a brother and sister. And this is shown here. This is the sibling match probability by virtue of the patient age according to ethnicity. And interestingly, you can see the ethnicity for the blacks in this age in the 40s is the highest. But, we don't start using donors unless it's a very specific situation and they're very young. Now, the histocompatibility story is another topic in and of itself. These are data that were published a few years ago, basically projecting the likelihood of finding an alternative donor. That is, someone who's not in your family who has the same bone marrow type as you, that is the HLA type. And you can see here that if you are of Northern European ancestry and you're Caucasian, your likelihood of finding a match in 2017 is really pretty good. That's because most of the donors, 70+% of the donors in the National Marrow Donor Program and other registries around the world are white, Caucasian, Northern European ancestry. When you start getting down here to Pacific Islanders and Native Americans and others, the likelihood of finding a match is much less, and so it is an issue. Now, what I'm going to focus on today is talking about the cells that are collected from either the blood or the bone marrow and what that means to the person donating those cells. And I'll show you the yin and the yang of this because we talk about stem cell or graft sources. It's changed a lot. And so here's some data from about 10 or 15 years ago. The green is bone marrow, and you can see that bone marrow was used a lot, but it's used less in this period, and if I had the data, it would be even lower here. And blood, mobilized blood, which can be induced with hematopoietic growth factors, and I have a slide to show this. Hematopoietic growth factors with the cloning of that of the genes, persons or patients getting hematopoietic growth factors stimulates the bone marrow and forces the normally cells living in the bone marrow onto the blood. So you're collecting bone marrow from in the blood, and that's a mobilized blood. And you can see that that's gone up. So we have started to change our practice. And if you start to look at a very important point, how old the donor is, one of the themes I'm going to point out to you is that it's not just the older donor doesn't have quite as many or as good cells as a younger donor, but an older donor isn't so resilient. And I'll show you data where one has to be careful because older donors can suffer consequences. And these are not patients, and we're making somebody sick. So one needs to be careful. So here's some data showing from the European Blood and Marrow Transplant Organization how the median age with 20,000 donations, hematopoietic cell donors back here in the early 90s to the present, we're using older and older and older siblings for mobilized blood. The yellow is bone marrow from siblings. That's been pretty constant, as is unrelated donors. These are marrow, and we didn't start using unrelated blood until about 1996. And I will tell you that we at Case Western Reserve University were the first medical center that actually did the first mobilized blood procedure for the National Marrow Donor Program. So this situation is also important because if one studies the biology of what happens to us when our hair turns gray and our skin wrinkles, aging is associated with clonality, and that is not a good thing. So being on this planet for a long time, you get exposed to cosmic rays and God knows what else. And you can see here that by virtue of age on the horizontal scale, that the percent of people who develop, this is clonal hematopoiesis, where the cells are now starting to become uniform, not a good thing. This translates into the increased risk of cancer. And you can see that people who don't have clonal hematopoiesis are in pretty good shape, but people who start developing clonal hematopoiesis go on and get hematologic malignancies. So one also has to add caution of using older donors. Okay. Now, the historic perspective, again, with the in the late 1980s, the recognition of the genes that control hematopoiesis and the cloning and then the commercialization of GCSF and GM-CSF, it became easy to administer these recombinant hematopoietic growth factors to people. And in the case of autologous transplants, where people would donate their own cells for him or herself, usually myeloma, lymphoma, diseases like that, that this quickly became so 99% of autografts use mobilized blood from a person with G or GM or other stimuli to the marrow to make the marrow release cells into the blood. But you also have the advantage of not doing a bone marrow harvest where you put the person to sleep, you stick needles into their pelvis repeatedly, and it's easier to do as an outpatient. So with the recognition that you could use mobilized blood from sibling donors, you got higher doses of all the cells we wanted. These are the CD34 are the stem cell, CD3, 19 are T cells, and CD56 are NK cells. These are the cells that affect elimination of the cancer. And so people began to wonder, if we can do this in autologous transplant, that is mobilized blood, can we do it in sibling matched donors? But we probably shouldn't do it in unrelated donors because we'll make GVH. I want to show you the data to back up this feature. So the group at the Fred Hutchinson Cancer Research Center in Seattle, Washington, put together this prospective trial, and I'll make the distinction between prospective data and retrospective data. They did a 3-center study, including City of Hope and Stanford, in patients that had hematologic malignancies and a match-related donor, and they compared the use of just giving the bone marrow, which is collected in so-called steady state in the operating room, about a liter of marrow over about 2 hours or so, versus mobilized blood, where you give hematopoietic growth factors, use an apheresis catheter as an outpatient, and over a period of 2 or 3 days, these 2-hour procedures, you get equivalent, actually more cells here. When you give those cells to the sibling who has gotten the chemotherapy to eliminate the malignancy faster engraftment with blood, you can see that the neutrophil count above the critical value was 5 days faster, 16 versus 21, and the platelet count was 6 days faster. And this is not inconsequential. As you know, the longer you are neutropenic, the greater likelihood of serious problem. When they looked at the incidence of this syndrome, graft versus host disease, where the cells from the donor couldn't recognize and attack the recipient, they didn't see it, and that's one of the themes. So there's been variability with acute GVH. However, chronic graft versus host disease, in most of the studies that I'll show you, this is where the cells that have arisen from the stem cell of the donor and without having undergone the immunologic morphosis, the thymus and the other signals aren't there. Chronic graft versus host disease is a bigger problem, but not in this study. So here are the data to support that. I'll march you through these. You can see that chronic graft versus host disease was in this study wasn't different. Survival was slightly better with the use of blood. Acute graft versus host disease was a little bit higher with the mobilized blood than bone marrow, but in the end of the day, the outcomes were the same. So in this trial, I'm sorry. So the outcomes were the same here, with a little bit better here. Another study that was done retrospectively to confirm this, again in sibling donors. This is a European study, a little higher with blood, giving a graft versus host disease acute, but at the end of the day, same survival. So this is what's known as a forest plot, and this is where people look at data with this being unity, and if something falls to the right, that would favor stem cells as a better graft. If it falls to this side, it would favor bone marrow. And I'll run you through these different categories, but it's important to recognize that there is a theme here. And so what you can see here is if one looks at a meta-analysis of those many, many studies, acute graft versus host disease, lower of all kinds, wasn't different, but worse graft versus host disease, acute a little higher with mobilized blood. And as I said earlier, extensive and any stage chronic graft versus host disease is higher with mobilized blood. So this is a very, very important take-home message that chronic graft versus host disease is a concern because it is the feature that gives the graft versus tumor, but it is also the feature that debilitates the patient and has them to be on lifelong or near lifelong immunosuppressive therapy and all the attendant ravages. If one looks at early stage of getting a transplant, either blood or bone marrow, no difference. But late stage cancers do better with patients that get mobilized blood. So that makes sense because mobilized blood has activated cells. They're more likely to cause graft versus host disease, especially chronic graft versus host disease, and so they're more likely to get rid of advanced cancer. So we're walking a fine line here between benefit and risk and how you select a graft. This is also from their data for overall survival. This is all the countries that participated and put patients on those trials. And you can see here when we break it down, again, early stage malignancy, that's like AML or ALL in first or second remission, versus late stage malignancy, people who are getting a transplant with active disease. A mobilized blood is a better graft. It's statistically significant because you have these activated T cells and other cells that are going to be more active for graft versus tumor. Given the fact that the bone marrow doesn't have as much effect on getting rid of the cancer, you have a higher relapse rate in patients getting bone marrow. And this is the take-home message from all those data. Basically, if you use mobilized blood versus steady-state bone marrow, you get a faster neutrophil and platelet recovery with mobilized blood. You do have the problem of more chronic graft versus host disease and its debilitating features. Mobilized blood is superior if you look at advanced malignancy, where you got to get rid of active cancer. It's the same in early malignancy. And all these data supported the fact that if you did this successfully in sibling donors, you could try to do it in matched, unrelated donors, and that's what they did. Now, for those of you who don't think about this like we do, mobilized blood versus marrow in matched, unrelated donor, or MUDs, there are more than 25 million altruistic people in the world who have given a sample of usually blood. You can do this on T lymphocytes for looking at the potential for being a donor. Well, we now know that you don't necessarily have to do it only on blood as a screening test. And you all have watched Law and Order and NCI, and you know they scrape the inside of the cheek or even spit, and you can do the DNA testing on simple things. So that's actually revolutionized how many more people can get into the donor registries. And then when you find someone with today's computers, between the patient and the recipient, you can go to that individual and you can actually get a blood sample to confirm that the screening saliva or buccal mucosa does give you your desired cells. Now, I'm a big proponent of prospective data, and here is one of the most important studies that was done. It was done, in the Blood and Marrow Transplant Clinical Trials Network did this trial. Basically what we did was we took people who did not have a brother or a sister as a match and did unrelated donor, whether the unrelated donor should get a mobilized blood graft or a steady-state bone marrow graft. This was a really, really, really complicated study because now you've got to do informed consent on two ends. Is the patient, the recipient, willing to get a mobilized blood versus a bone marrow graft, A, and the donor had to be consented separately because was the donor willing to have a general anesthesia and have marrow collected or come in day after day to get immobilized blood. So this trial was done worldwide, and what you can see here is, again, what I showed you earlier, the survival data in the recipients was similar, but neutrophil recovery was 5 days shorter with blood than marrow, as was platelet recovery, and acute GVH, which again seems to be the thing, there wasn't any real difference in acute, but chronic graft-versus-host disease was higher in the blood. Now, another benefits, as I already alluded to, was the relapse actually was a little bit better, but not statistically better. But graft failure was actually lower with blood than with marrow because you're giving an order of magnitude more cells with immobilized blood. When you do a marrow harvest, you're just sticking the needle in the posterior superior iliac crest on the left and the right side of the hip. When you do a mobilized blood graft, you recruit cells from all over the body, and so the likelihood of engrafting failure is less. Here are the data from that study. Again, neutrophil, this is again on the vertical, is the time to get full neutrophil or platelet recovery versus days from transplant. You can see that neutrophils come back faster with blood, as do platelets. But the overall survival is equivalent between patients who got blood or marrow. Again, these are leukemia or myelodysplasia patients, and overall survival was the same. The relapse rates were similar with both graft sources. Acute graft versus host disease did not differ, as was the case in the sibling matched. This is unrelated donor. But again, chronic graft versus host disease was significantly worse with mobilized blood than with bone marrow. But at the end of the day, doing an intent to treat analysis, they're equivalent. So it's a wash in that regard. And so you say, well, if it's easier to collect mobilized blood, why don't we just do that? Well, it's a very complicated story because we went back and we looked at the data. Now we're many years later, and we actually went back to the donors in this case because the transplant results in the recipients were similar survival. The relapses were the same. But if you looked at the people who got the graft from unrelated donor, they did not have the same amount of chronic graft versus host disease. This is a big deal because they're not on immunosuppressives, and they're more likely to return to work. And there was not one single thing that showed that blood was better than marrow. And even though today now more than 80% of the time we use mobilized blood, so there was some people that say maybe we should shift back to bone marrow as a graft source rather than mobilized blood. I'll come back to this in a second. I wanted to show some retrospective data now for mobilized blood versus bone marrow. And again, these are data from the Europeans. The incidence of chronic graft versus host disease as a graft source is higher with mobilized blood than with bone marrow. And again, if we looked at acute myeloid leukemia in remission, the data of getting a graft from blood or marrow is the same. But in people who get a transplant, when you're taking somebody who was transplanted who has active leukemia, again, you get more potent allogeneic effect with mobilized blood. And so you can see here, not great results overall, but certainly statistically better with mobilized blood than with bone marrow. But that's with myeloablative, meaning that you throw the kitchen sink at the patient, where they really, really get treated. The conditioning is intense. The field has moved a bit, and we now don't give quite as much conditioning. We call it reduced intensity conditioning. It's still pretty potent, and people will not recover their counts unless you give a graft. If you look at the data, retrospectively unrelated donor and acute leukemia, again, the use of mobilized blood is a little worse because of chronic graft versus host disease, but relapses are better because of chronic graft versus host disease. So we're walking this fine line because of chronic graft versus host disease, even in the reduced intensity conditioning setting for acute myeloid leukemia. More chronic graft versus host disease, more infection, but lower relapses. It's a wash. The results of blood versus marrow give you the same pretty good 50% leukemia-free survival, not bad. And this is a recent study that we just published that basically compares essentially the same thing. This is data comparing blood versus marrow. No significant differences at 5 years between blood and marrow. And again, the themes. So what are the conclusions of all that? The conclusions are that both match-related or sibling donors and matched unrelated donors give you similar results. That is, that you get mobilized blood grafts, give a much faster reconstitution of neutrophils, platelets, fewer transfusions, less antibiotics, fewer opportunistic infections, but at a price of having more chronic graft versus host disease with mobilized blood. And the survival rates in the recipients are similar, with the exception that in advanced malignancy, when you're going into a transplant, the chronic graft versus host disease results in lower relapses. If you also look at the psychological issues of the patients and the recipients, more burdensome with chronic graft versus host disease. Now, these next couple slides are a little complicated, so I'll try to march you through it quickly, because sometimes, despite our best efforts, engraftment failure occurs. That means we collect all of these cells at some other center, and they are shipped in all around the world. As I showed you earlier, more than 25 million donors. The prescription says collect such and such a number of cells based on body weight. However, sometimes these cells are given intravenously and they don't grow. Engraftment failure. You go back to the original donor and say, can we do it again? Or you go back to the sibling and you say, can we do it again? And so we looked at that, and we wanted to see two things: whether the side effects were worse in a donor who had to get a second collection, whether it be blood or bone marrow, and whether the yield was similar for a second. And so we did these really complicated comparisons. We just published this paper. You can certainly look it up online if you wish. Second-time donors giving marrow. The first donation might have been blood, and the second was marrow. And we looked at just a single donation versus also second-time donors giving mobilized blood. So they could have given mobilized blood a first time and then mobilized blood a second time, or they could have done a marrow the first time and then a mobilized blood. And we looked at all this. So there's all these permutations and combinations. And we also looked at the time, how long it took to recover. So normally when we do this, we certainly wouldn't go back to somebody earlier than 1 month, although some of the data up here show some centers did that earlier. And we looked at the time between donations for marrow and the time between donations for mobilized blood. And here's what we found. Second, mobilized blood or bone marrow, really the donors had the same side effects, which I'm going to show you in subsequent slides, of skeletal pain from the needle in the hip or skeletal pain from GCSF stimulating their marrow and causing pain. You're putting 20 pounds of fruit in a 10-pound bag when you give hematopoietic growth factors and grow up the bone marrow in a confined space. People have pain. And if you look, there was a lower yield the second time. And we can identify some people who tend not to give us as many cells as we like. These tend to be people who either women or obese persons. And so here's the conclusions for most second donations. The experience is pretty similar to the first donation, but you get less cells. So why is this important? Well, this is important because when you're looking at a donor a second time, if that donor had a tough time, you really don't want to use that donor again. We have to be reasonable, and we have to decide when or if we would use a donor a second time. Now, that's sort of a big background leading to special considerations, which I think is sort of relates to the topic that I used in my title, and that is looking at the differences of the donors from the standpoint of whether you're going to use mobilized blood or you're going to use marrow. And there's a lot of rules and regulations for using unrelated donors, not so much for related donors, okay? There's no age restriction if a brother or a sister is donating at your center. There is for the National Marrow Donor Program and other things. There's usually a limit, which I'll get to. There's a limit to how many times you can ask somebody to donate. Usually it's once, sometimes twice, as I've shown you. And a related donor might be asked to come back more than once, especially for this special situation called donor lymphocyte infusion. That's basically where you go in and you just take steady-state blood to collect the lymphocytes. You're looking for the lymphocytes. The donor's already engrafted, but you want more of an immunologic bang to get rid of the cancer. Unrelated donors can't get as much G-CSF as sibling donors. This is a lot. This can really cause severe pain. I've already mentioned donor lymphocyte infusion. And we are coming up with new and novel ways of mobilizing bone marrow cells out of the bone marrow into the blood. We can do this in the related donor, but boy, the unrelated donor, really very conservative. You got to stick with G-CSF, and you got to use healthy blood donation guidelines where at a center, people will look the other way and take somebody, and this is part of the meat of my talk, take somebody that maybe shouldn't be a great donor and going because of family obligation. This is a conflict of interest of sorts. One needs to be very careful, and in fact, the person talking to the donor cannot be the person taking care of the patient. They have to be totally separate at a center, and certainly at the National Marrow Donor Program and other places. They have to be clearly altruistic and a volunteer, and there are donor advocates. Okay, why is this such a big deal? I already showed you some of the data about age. If you look at some of the issues of maintaining all the computer hardware for the HLA types and how old and the gender and all this stuff, we're talking about a huge amount of money annually, $30 million, to maintain registries where 5,000 patients are getting cells from either marrow or blood from volunteer donors. And when you break this down by the age of the volunteer donor, early adult, middle, and later adults, there is a 5.5% increase for overall mortality for the recipient when the graft is getting older and older. And so now the National Marrow Donor Program says, hey, we don't want donors unrelated that are over 44. Sounds like Abby Hoffman, never trust anyone over 30. If you can remember the Chicago trial, this is Democratic politics many decades ago. Most people don't know what I just said. So the National Marrow Program is now trying to restrict to even younger adults. And if you start to do that, again, you'll save more money, and maybe that's a good thing. However, there are certain populations that may suffer as you start dialing down the age of somebody who's willing to give cells. What do I mean there? Well, if we look at only donors now, it's 44 is the age limit. If we only use the donors in the 18 to 32 year age, it's going to be okay if you're of Northern European ancestry. But if you're African American, boy, this is going to really knock down the likelihood of an African American getting a graft. And so although there's more money, this is a problem. And so now people are saying, well, let's lower it because we can use other sources from going beyond just an adult matched unrelated donor. We can use this discarded source called umbilical cord blood, which is where blood is taken from the afterbirth, the placenta, or what's called haploidentical grafts, a half match between a parent or a sibling or a child. I can't go into that in detail other than to say this is another avenue that people are going forward. Now, what about the issue of sibling donor age? I keep coming back to age. This is not age discrimination. This is science. And there are only 5 studies when you go through the literature that have actually looked at sibling donor age and whether it makes a difference between a sibling donor and a matched unrelated donor, leukemias, various types of regimens, and some all across the board. I've summarized it here. Only retrospective data, and there's no clear signal of whether a sibling donor, let's say you had an 80-year-old sibling donor, but maybe you could use a 40-year-old matched unrelated donor, which one could you choose? Well, it turns out that there's no clear signal of which one would be better because there's so many factors. A patient has treatment and prior treatment and other disease categories. There's so many factors, but we realize that older donors may have their own cross to bear. The immune system is older. There's reduced diversity of the T-cell antigen repertoires. There's fewer naive T-cells in an older person. There's increased memory cells because you've been around for a while. Increased in pro-inflammatory status, not good, that's GVH. And decreased Tregs. So do you really want to use an older donor? Well, the answer is no if you can help it, because the biggest disadvantage is to the donor. And I would recommend if you can use a much younger donor, I would use that in my choice going forward. Now, one word about transplant. I published this study a number of years ago because I was concerned that I was getting grafts from Australia and New Zealand and places like that where the graft was in transport for a long time, sometimes even more than 24 hours. And so we actually studied this. We got together all the data from the National Marrow Donor Program and the CIBMTR, and we looked at about 1,000 unrelated donor grafts versus about 500 mobilized blood grafts in leukemia and MDS patients, and we looked to see if there was a difference in how long they were in transit from all over the world. It wasn't a difference, but what we saw was when you put a graft from a marrow into a patient that had been sitting outside the body for a long time, in this case more than 20 hours, the time to recover, those cells were injured, and the time to recover platelets in people getting grafts that had been in transit for a long time is much higher, especially when it's more than 20 hours. And so this was with marrow without blood. And so again, when you're writing the prescription of where you want the graft and where it's coming from, if it's going to be on the other side of the world, maybe you don't want to request marrow with the advantages. Maybe you want to request bone marrow. So in the remaining part of my talk, I want to scare the pants off people who have to take care of volunteer donors because they're not patients. And it would really irk me to read my notes, to read notes of other people who would talk about the normal patient and this, and they're not patients. And it would always make me very, very nervous doing a marrow harvest on someone who doesn't have major medical problems. We can put them at risk. And this is one of the motivations for that. I lifted this from the Los Angeles Times about almost 20 years ago now. Peter Warren, staff writer, wrote this story of a bone marrow transplant donor's sobering brush with death. And here's the quote. This person was 44 years old. She nearly died having marrow extraction to help a fatally ill man. Her ordeal is a reminder the procedure is not risk-free. So this harvest, and harvests are done all over the place, it was done in a hospital in California, and I don't know what they were doing, but they introduced Staphylococcus into this donor's pelvis, posterior iliac crest. The poor lady was hospitalized for 65 days because of staph osteomyelitis with, you can see here, hepatic and renal failure. And actually, it didn't even help the recipient because that person died 3 months after the infusion. But the donor was left with a limp and a speech defect and constant pain. So, we have to be vigilant. And here are the data in matched unrelated donors from Mike Pulsipher's elegant trial. What he did was he took data and compared blood versus marrow in the United States for adverse events. And over here is bone marrow, and here is mobilized blood. And this is the cause of the serious adverse events, which I'll show you on the next slide. If you take someone to the operating room and you stick a needle in their posterior iliac crest many, many times, you can cause a lot of pain. Hopefully you won't cause osteomyelitis, as in the patient I just described. But you put that person to sleep, and maybe they're going to have a post-op pneumonia or something. If you collect, so let's just do it as an outpatient, give them hematopoietic growth factors, GCSF, and then use an apheresis. Well, it turns out that in this country, people are more and more and more obese. Think about starting an IV on somebody in this day and age. We insert central venous catheters into their upper extremities. This can cause pneumothorax, hemothorax, etc. And so apheresis itself may not be a benign procedure, and giving GCSF, as I described to you earlier, may cause lots of side effects, including severe bone pain. And here's the numbers. So what you can see here is that if you look at these serious adverse events, if you look, the dark color is bone marrow, you can see that 7% of donors had life-threatening events with bone marrow harvest compared to mobilized blood. Lots of them got hospitalized and had significant disability afterwards. So it's not a benign procedure. And when we went back and looked at our own data from the BMT CTN 0201 trial that I described to you, which was the randomization of blood versus bone marrow for unrelated donors around the world, you can see here that the complete recovery time was much slower with marrow donors. So here you can see if we just looked at our donors in this country versus donors worldwide in this international trial, you can see that the time to recovery, that's the vertical axis, that the donors that gave marrow recovered much slower than the donors who gave mobilized blood. And part of the problem is shown on this slide. You can see that for skeletal bony symptoms, look at this. This is marrow, lots and lots of pain and other things from having the needle in your hip repeatedly and more fatigue. So it's not a benign situation, and part of the problem is that people have lost the art of harvesting marrow. It's now easier to write a prescription, send the donor to an apheresis place where if maybe you have to stick in a catheter, central venous catheter, but fewer and fewer people know how to do this. Now, in my professional career, I did well over 1,000 bone marrow harvests, and I used to teach people how to do diagnostic marrows and harvests. I'm a dinosaur. There are fewer and fewer centers, and this group, I got these guys in my editor-in-chief capacity of this journal. I got these guys at the Karolinska to look at the content of the donor grafts from bone marrow at their center where they do a lot of harvests versus their data where the cells would come in from the world at large. And it doesn't require much imagination to realize that the Karolinska group got many more. These are the stem cells, CD34. This is how we measure the graft potency, more stem cells. You can see their own collections are much better than what comes in from the other world at large. And in fact, other people have looked at this. This is from a paper that we just published from the NMDP. You can see that for centers that do fewer harvests, that, in other words, you're doing less than one every 2 months versus more than one every 2 months, you're just not as good at it. And you can see here that there's more symptoms in the donor in a center that doesn't do as many harvests as when you do harvests. And so here's the recommendations. It's an art. You can't go in there and stick a needle in the hip and take out 50 mLs at a time and be done. You want a it's just like aspirating bone marrow for a diagnostic test. We're now in acute myeloid leukemia. We talk about minimum residual disease. In other words, there's still very, very, very fine, small amounts of leukemia. If you suck out a lot of cells out of a marrow, you're getting blood. You're not getting marrow. So you want to get small volumes with each aspiration, and this is why it takes so long. Talking about an hour or two in the operating room, and the guidelines are not to take more than 20 mLs from a donor. That's a lot. You're talking about 1.5 liters in some people, and you have more experience. So we're going forward, but I want to show the data in these last few slides of 2 surveys. These are data from the first survey. These were conducted over about a 20-year period, mostly in Europe, of collecting either marrow or blood, fatalities in the donor. So in related donations, 5 deaths. They were all males, so I'll show you on the next slide. While the incidence is very, very low, these are related donors, no deaths in unrelated donors, it's very serious. So you can see here that these 5 deaths, 4 had mobilized blood. Everybody thinks that's so safe. 1 was a marrow donation. And again, what's happening is, there cardiologists in the house? Can I have and raise your hand. How many are cardiologists? Is there a cardiologist in the house? Maybe somebody shouldn't have been passed the clearance test here to have somebody, a so-called volunteer donor, dying giving mobilized blood. And here's the second part of that survey. Again, very large numbers, 37 severe adverse events, a little more with blood than with marrow. Development of hematologic malignancy, obviously we worry about that. I showed you very early on the data for clonality, especially with older people. Fortunately, it turns out that the likelihood of a donor getting cancer or giving it to somebody else doesn't exceed what one would expect in the age and gender adjusted population. But here's the data from this second part of the survey. Very, very, very scary. Look at this, 25 serious for bone marrow, for blood donations, and 12 for marrow. And again, these are, for the most part, cardiovascular events. One cardiac arrest in a normal donor can ruin your whole day. Just a joke, but it's a serious event. It's cardiac arrest, supraventricular tachycardia, pulmonary emboli, stroke. You can see all these things, including splenic rupture. And in fact, when I talk to the donor, I always point out to them that you're not only stimulating the bone marrow to grow and cause bone pain, you're stimulating the spleen. And Pat Stiff and I and others did a prospective study where we gave, before we did G-CSF administration, we did an ultrasound of the spleen, gave them the G-CSF for the week to collect the cells, and repeated the ultrasound and found that the spleen got bigger. No surprise. Again, it's fortunately rare, but splenic rupture in someone that's not a patient is of grave concern. And here are the data showing that, again, 3 bloods and 2 marrows resulted in the death. And there is a project now, it's called Project Notify in the U.S. and Brazil, where people are looking at this very, very carefully. We have to protect these persons. So there's no obvious reports of transmission of active infection, and there's only 2 reports of transmission of malignancy from a donor to a recipient, and those are shown here. This is vanishingly rare. I don't know what ultimately happened to the recipient, but these are the sort of the so this has led people to be more and more vigilant, looking at blood counts and looking at chromosomes and all kinds of stuff. But the conclusion of this trial we just published, studies of large numbers of unrelated donors have shown that the risk of developing cancer, this is again from the GCSF, is not increased. So GCSF is pretty safe. Nonetheless, there's an issue. So my last couple slides are, again, these are the take-home messages. There's really no difference between, in major outcomes between blood or bone marrow, with possibly the exceptions of an advanced malignancy having fewer relapses and this chronic graft versus host disease impairing their quality of life. But you can see mobilized blood gives you 10 times more cells than marrow with faster marrow recovery. The lower likelihood of engraftment failure because you're putting so many more cells in that aren't going to get kicked out, but higher graft versus host disease and mortality, and again, the likelihood of advanced disease being better controlled. One other take-home message, especially in pediatrics, is if somebody doesn't have a malignancy, you're doing a transplant for a hematologic disorder, an immunologic disorder, there's no benefit to graft versus tumor, graft versus host disease. So in non-neoplastic disorders, you always should request a marrow. So this is my last slide. Donor events that cause serious, donor deaths or serious adverse events in donor, they're rare, but these are not patients. You're making something bad happen. You really, really need to watch a donor and enforce these strict eligibility standards. Have a third-party person who's not related to the patient. You can't have coercion to monitor that person and monitor that donor. Follow them up. And there are formal guidelines with the NMDP and other things. And this is all being spearheaded in very specific fashion. And now we're finally doing our job and looking at the donor. And so this is my last slide. I did think that we couldn't do any of this stuff unless we had brave patients and their families making sacrifices to help us do what we need to do. So I want to thank you for your attention, and I'll take any questions in the remaining time. Thank you.
Thank you, Dr. Lazarus. Thank you. Very well described. And I guess before this, I was thinking, I've always thought about the discussion with the patient. And now I'm thinking, well, how does that discussion with the donor go? Can you tell us more about what are the specifics about the reality of identifying a donor? Particularly somebody who is not a patient, you haven't known them before, and there's this discussion about what may or may not happen if you contribute to this process.
So I think this is again the art of medicine. Okay, somebody is assigned to your clinic who is an unrelated donor, and I was very, very fortunate to have a nurse with whom I worked for many, many decades. She would go in and she would prep the donor. But there's a video that they look at. By the time they come to us, they have been through so many screening processes that you're not twisting somebody's arm from the unrelated, whether it's through the American Red Cross or the local blood center. A altruistic person who's read about it online or knew somebody and says, I want to help. They've watched the video. They've been interviewed. They've been screened for medical exclusion. If you had miliary TB, you're obviously not going to use them. By the time they come to you, in the vast majority of cases, they get it, and then you do what I do. You just sit down, explain what the process is. If it's mobilized blood, you have to tell them about insertion of a central venous catheter, because I've actually seen hemopneumothoraces and other such things. And if it's marrow, they may be debilitated for many weeks afterwards. So by the time they get to you, I think it's been pretty well worked out. I think the problem is it's the sibling where there's an issue. Gee, I flew in from Florida to see my sister. I'll do anything. You'll do anything. You know what's involved. Then they say, really? So you have to give them an out. We can't have conflict of interest, and we can't coerce somebody into donating. They really have to want to do it. So it's not as, I think it's actually easier now with unrelateds than with family members because of the obvious baggage.
Questions, comments?
Has anybody ever gone to the OR with Dr. C to collect marrow or?
We try to avoid that.
you're, that's unfortunate.
Do you have a comment?
So you never, it's like the Army, never volunteer for anything.
What efforts are going on to not need a donor?
I'm sorry, I don't understand.
What are the efforts going on to the point where we don't need a donor?
You mean,
Or you can create what you need in the laboratory? Are there efforts to do that, or utilizing other species, or synthesizing, taking just fewer cells and going into what we don't need?
So that's a very interesting question. So you can make that argument about, do we need a blood bank? And I'm sure that you are aware that people have tried to do this, and in fact, incipiently have been able to take blood products and to add cytokines and other things to grow up platelets, for example, or other. We haven't been able to figure out how to do this so well with neutrophils. But science is actually starting to go in that direction. The bone marrow is a very interesting organ, and it's like everything else. The more you learn about it, the more you realize you don't learn. The bone marrow is innervated with nerves, and there are all these new products that are coming out to stimulate the nerves to the bone marrow to make the bone marrow kick out more bone marrow stem cells. And in an individual person, maybe the day is coming where you can get them to kick out their own cells, basically have them draw some blood. We do this, we call this CAR-T now. You've heard of that. It's only $500,000, which is another dilemma that we face in medicine, that is the dollars under the curve and making these kinds of decisions. But I don't think this is Buck Rogers' kind of thought processes. I think that we have so much great science that there will come a day, I think in the not a little distant future, but where we can do just what you're describing, where we don't have to do so many things to other people, and maybe we can do it ourselves.
Right.
Good question.
Well, listen, we have a tradition here that we send good speakers, not the bad ones, good speakers back home with a baseball bat, a Louisville Slugger. Now, this happens to have been used by Roberto Clemente on his third game. No,
I wish. I saw him play many, many, many times.
Okay. So Hillard Lazarus, Medicine Ground Rounds, University of Louisville, November 9th, 2017. Thank you so much. And you guys have a good Thursday.
Thank you so much.
Did you fly here? Yes. Then we're going to send this by mail. They're not going to let you on the plane.
They won't let me on the plane. Where they think I'm going to do something to someone? Oh,
we've tried.
Boy, this is a wonderful gift. Wow. Wow. Thank you so much. Oh, yeah.
We need a picture.
Oh, can I extricate myself? Thank you.